Let us discuss the therapeutics of anti-epileptic drugs as per the objectives of lecture. We have to discuss the different cases of the epilepsy and their management. In the last session, we uh, studied the different drugs which are used in the management of the different types of the epilepsy. Just I will show you the brief chart again, the types of epilepsy and the anti-epileptic drugs which are preferred and the alternative one. For the partial epilepsy, simple partial epilepsy, the preferred drugs are the carbamazepine and the phenytoin. Complex partial epilepsy, the preferred drugs are the carbamazepine and phenytoin. And in terms of the generalized one, tonic clonic, or we can say granular epilepsy, the preferred drugs are the carbamazepine and phenytoin. Absence petitional epilepsy, the preferred drug is ethosuximide. Myoclonic epilepsy, the preferred drug is valproic acid. For the febrile seizure in the children, the preferred drug is phenobarbital, and the status epilepticus, the preferred drug is diazepam or phenytoin. And if this preferred drug, if the patient has documented hypersensitivity or contraindications or not get benefit by use these drugs, then in this case we can utilize alternative drugs which are listed in the second column. Let us see the cases. Case 1, a 16-year-old man is brought to the emergency department by paramedics after a series of grand mal seizures. Grand mal seizures. Now, this grand mal seizure is a type of the generalized seizure. He required repeated doses of IV lorazepam to finally control the episodes of the seizure. So, the case of the grand mal epilepsy, which is generalized one, and as we discussed in the lectures, the grand mal is also called as tonic clonic epilepsy. Tonic clonic. In the tonic clonic, as we know, there is a stiffness of the muscles and the jerk movements. For the management of this case, the healthcare department administered IV intravenous lorazepam to finally control the episodes. And here the series of the grand mal seizure series. So series of grand mal means maybe within some time period there are many attacks, more than one attacks, and if this attack is not able to control within a time, because it may leads to a status epilepticus, and the status epilepticus is an medical emergency. The question is, explain the mechanism and advantage of lorazepam in this case. As we know, the lorazepam is categorized as benzodiazepines. These are from the category of benzodiazepines. They act via the GABA receptor, and GABA receptor, that is gamma aminobutyric acid, is an major inhibitory neurotransmitter of the CNS. So lorazepam is from the category of benzodiazepines. Okay. So, mechanism and advantage of lorazepam in this case, as we know that the lorazepam is from the category of benzodiazepines, and in the benzodiazepines there are another drug, very well known drug, that is a diazepam and the lorazepam. So lorazepam, generally these are the GABA receptor agonist, and they uh, increase the GABA transmission, and we know that the GABA is gamma aminobutyric acid. It is an the inhibitory, major inhibitory neurotransmitter in the CNS. So it mechanism of action of lorazepam is gamma aminobutyric acid receptor agonist, increases the action of gamma aminobutyric acid. GABA depresses all the levels of the CNS, including limbic and reticular formation. What is what is the advantage of lorazepam in this case? As we know that the grand seizures or epilepsy may convert to status epilepticus, and it, in the case there is an series of the grand mal epilepsy, and if it is not controlled within the time period, it may lead to the status epilepticus, and the status epilepticus is a medical emergency. Lorazepam initially used to control the status epilepticus, which is medical emergency. So lorazepam is generally initially choice of drug in the management of the grand mal seizures. So, and after the control of the seizure, it is not the please keep in the mind, lorazepam is not used for the maintenance therapy, just to control or to manage the case. When the seizure is controlled, then we have to give maintenance therapy. Mention the one drug therapy that can be used for maintenance therapy, and here the carbamazepine or phenytoin. As we know, the preferred drug carbamazepine or phenytoin, these are the preferred drug in the management of the grand mal seizures. The mechanisms of actions of the carbamazepine and phenytoin is uh, as we discussed in the lecture, sodium channel blocker. Here, the role of the sodium ion is, as we know, that is very, very important. The role of the uh, sodium channel, because the when the sodium ion enters inside the cell, it causes the depolarization, and the depolarization causes the excitation. So we have to block the sodium channel, as we discussed in the lectures. Mention the three its special side effect. If we mention the carbamazepine, and what is the side effect of the carbamazepine? Ataxia, which is also known as gait abnormality, dermatological reactions, including toxic epidermal necrosis and the Steven Johnson syndrome. These are the special side effects which are not the common. Common adverse effects includes the GI disturbances like nausea, vomiting, uh, like that. These are the headache and dizziness. These are the common one, but special one is other than from the common one. And for the phenytoin, we know that the phenytoin is having the Phenytoin syndrome if it is taken by the during the pregnancy, and the gingival hyperplasia in the children is the common, or we can say special adverse effect. Let us see case 2. A 20-year-old school teacher was found in generalized spontaneous fit with loss of consciousness. With loss of consciousness. and generalized epilepsy. The patient was rapidly injected with an intravenous drug by the healthcare attendant. Within a few minutes, the patient started to respond adequately to the injected drug. In the hospital, full history and through clinical and investigations were done, and a final diagnosis of generalized tonic clonic epilepsy seizures was made. Now, tonic clonic granular epilepsy, generalized same, generalized tonic clonic, or we can say granular epilepsy. What is the question? What is the most likely injection the patient had received, and give two examples of the injections. Generally, uh, for the grand mal epilepsy, and there is a loss of consciousness, the preferred drug which has to be given by the intravenous route are the carbamazepine and the phosphenytoin. Now, carbamazepine is an intravenous drug, and also phosphenytoin is intravenous drug. Phosphenytoin, it is a prodrug of phenytoin. Phenytoin, because we discussed in the previous lecture, the phenytoin has low solubility, and due to low solubility, the intravenous administration may be affected. So we need the phosphenytoin, which is a prodrug and more soluble. Phosphenytoin is a prodrug, and it is metabolized by the livers. It is metabolized by the cells erythrocytes to the phenytoin, and which is the active form of the phenytoin. So generally preferred drugs for the management of the tonic clonic epilepsy are the carbamazepine and the phosphenytoin. Now, from these two preferred drugs, which drug has to be given as per the patient history? Now the patient is unconscious, so according to the availability, or according to um, the drug's property, we can use maybe carbamazepine or the phosphenytoin in the management of the uh, generalized tonic clonic epilepsy. Alternative drug is available is phenobarbital. Phenobarbital is an the alternative. If the patient has the documented hypersensitivity or contraindications, then we can use phenobarbital. Second question, what are the therapeutic precautions to be taken in account of regarding the injected drug? As we know that the phenobarbital is from the category of the barbituric acid. Phenobarbital is from the category of barbituric acid, and the barbiturates, they generally depresses the central nervous system, and the most important is respiratory system. So if the phenobarbital is given by the intravenous route, there may be chances of the respiratory depressions. So take the precautions if the patient is already having apnea. If it is given by the subcutaneous route, highly alkaline and may cause tissue necrosis. Phosphenytoin, risk of the hypotension and arrhythmias with infusion rates that exceed 150 milligram per minute. Risk of hypotension and arrhythmias with infusion rate that exceeds 150 milligram per minute. So we have to take the precautions while we are using the phosphenytoin for cardiovascular patient. Careful cardiac monitoring is needed during and after the administration of IV phosphenytoin. because these events has also been reported at or below 150 milligram per minute infusion rate. So the patients of the grand mal epilepsy, if we are using phenobarbital, as phenobarbital is a derivative of barbituric acid, and we have to take care of the respiratory depressions. And if we are using the phosphenytoin, we have to take care about the cardiovascular disease, because the risk of hypotension and arrhythmias reported. Next question: can you use these drugs forms chronically in this patient, and why? As we know that the therapy intravenous therapy is not recommended for the chronic use, because we know that there is intravenous therapy is only for the emergency purpose and for the management of the case, or for, we can say, management of the seizures. So we can say no, injected drugs have lots of adverse effect if given chronically. Intravenous doses should be used to control or manage the case in case of emergencies. Once the patient is under control, we have to use oral preparations. Next question: what are the side effects of drug if used chronically? As we know that phenytoin is responsible for the gingival hyperplasia, osteomalacia, megaloblastic anemia, hirsutism, hypertrichosis, excessive hair growth, hyperglycemia, glycosuria, and the drowsiness. These are the common adverse effect. And if we use by the intravenous, this adverse effect may precipitate excessively. Next one: what is the drug of choice as a long-term management? Yes, if once the patient is under control, then we have to give the oral therapy, and the preferred drug for the management of the long-term therapy for the granular, or we can say tonic clonic epilepsy, is carbamazepine, available in the oral form, or we can give phenytoin, available in the oral forms. Now next question is about the drug-drug interactions. If the patient was on oral contraceptive pills, what anti-epileptic drugs should be avoided, and if it is necessary to use these drug? Generally, we have to know the drug-drug interactions, and we know that the most of the common drugs, including phenytoin, phosphenytoin, benzodiazepines, then lamotrigine, phenobarbital, and benzodiazepines including lorazepam and diazepams, these are responsible for enzyme induction. Enzyme induction. And if there is enzyme induction, we know that what is the adverse effect of enzyme induction. Because if the enzyme is induced by the drugs, the metabolism of other drugs will increase, because there is enzyme induction. And if the metabolism is increased, the drug is easily excreted from the body. We can say the clearance rate of the drug will be increased. Suppose, let us see the example of oral contraceptive pills. If the patient is taking women patient, and she is taking oral contraceptive pills plus phenytoin, or we can say benzodiazepines, What will happen? As we know that phenytoin and benzodiazepine increases the clearance rate of oral contraceptive pills, because in due excess of the enzyme, the drug is metabolized rapidly and excreted from the body. So what happen if the oral contraceptive pill is metabolized rapidly and excreted from the body? What will happen? The effective therapeutic concentration is not able to achieve. And if the effective concentration is not able to achieve, what will happen? So the drug will be not effective. So here the contraceptive pills are used for the prevention of the pregnancy, and maybe the pregnancy is not able to prevent. If it is necessary to use anti-epileptic drugs, the patient can use alternative contraceptive methods, available alternative contraceptive methods. If she doesn't need hormonal contraceptive, she can use physical or barrier methods of contraception. What alternative hormonal contraceptions for this patient? Injectable depot medroxyprogesterone acetate, DMPA. What is the significance of this drug? Now, this is, as the name is, injectable. So, this medication is given by the intravenous route, and it is just one injection for 3 month. One injection is for the 3 month. So, injectable depot medroxyprogesterone acetate is given. What happened? What is the significance? Because it is high clearance drug, its clearance is directly dependent on hepatic blood flow, and enzyme induction would have little effect on the metabolism of this drug when it is administered by injection. So what is the logic? We can say that the injectable contraceptive may having less drug-drug interaction when it is given with the oral dose of enzyme inducers anti-epileptic drugs. But but the other contraception method, like the barrier method, also initiated with hormonal contraception, and this is an advice for the women patient who is on anti-epileptic drugs and who is also taking oral contraceptive pills. Let us see case 3. Ali, a 6 month year old. Now, 6 month year, we know that, just a minute. Ali, a 6 month year old, mentally retarded, has bots. Bots means short time, short period, or brief recurrent myoclonic jerk with sudden extension of the body and limb, and the diagnosis was infantile spasm. The infantile spasm is characterized by the brief, recurrent myoclonic jerk with sudden extension of the body and limbs. What are the drug of choice to control Ali's fits? What are the drug of choice to control Ali's fit? Here, the steroids, dexamethasone, and vigabatrin, which is the GABA transaminase inhibitors. So the GABA transaminase inhibitors increase the level of GABA at synapses and control the seizures. So vigabatrin and the dexamethasone, these are the preferred drug in the management of infantile spasm. So here you had to remember the infantile spasm. You have to remember the infantile spasm. If there is an infantile spasm, the preferred treatment is the steroid dexamethasone and vigabatrin, that is GABA transaminase inhibitors. What are the side effects? Vigabatrin cause permanent vision loss or maybe the weight gain. Can you prescribe valproate to this patient? Why? No, because it can produce severe hepatitis in this age. So if there is a fatal hepatotoxicity, if the patient is less than 2 years of age, there may be the fatal hepatotoxicity. So the valproic acid should be avoided in the patients less than 2 years of age. So if there is an infantile spasm with the extension of the body limbs, the best drug and the preferred drugs are the dexamethasone and vigabatrin. So this question is also important for your exam point of view, for the infantile spasm, vigabatrin. Next case, case 4. Radhi, 10-year-old, has history of 2-year brief seizures lasting for seconds and the diagnosis of absence seizure or petit mal. Generally, the absence seizure and petit mals are seen in the children's from the age 2 to 12 year old of age, and absence seizure and petit mal is characterized by there is an the seizures less than some seconds, less than 10 seconds, absence seizures. And as we discussed in the lecture, what is the first line or choice of treatment for this patient is ethosuximide. So for the absence seizure, we have to use ethosuximide, which is the preferred or drug of choice. Ethosuximide depresses the neurotransmission in motor cortex.